For our discussion of intestinal protozoan infection, let us start with opportunistic intestinal coccidian parasitic infections. Cryptosporidium, Cyclospora, and Cystoisospora are the intestinal coccidian parasites that can cause opportunistic infections in HIV infected patients, producing profuse watery diarrhea. They can be diagnosed by detection of acid fast oocytes in the stool microscopy. Cryptosporidium species infecting man is now classified into two separate species: Cryptosporidium parvum, mammals including humans, and Cryptosporidium hominis, primarily humans. Other species infect wide range of mammals but not man. Cyclospora cyatensis is the most recently described coccidian parasite as human intestinal pathogen. Isospora belli has been recently named as Cystoisospora belli. So, C. belli is the only species that infects man. No other animal reservoir is known. Morphology: the life cycle of coccidian parasites passes through various stages such as oocyst, trophozoite, schizont, which is a meront, merozoite, and a zygote. Oocyst is the infective form to man as well as the diagnostic form excreted in the feces. It is round to oval, surrounded by a cyst wall and bears sporozoites. The oocysts are acid fast in nature but do not stain by iodine. They are extremely resistant to routine chlorination, heat, and other disinfectants. In Cryptosporidium, two types of oocysts are demonstrated: thick-walled and thin-walled. Life cycle. The life cycle of Cryptosporidium is discussed. It completes its life cycle in single host, man or other animals. Infective stage. Sporulated oocysts, both thick-walled and thin-walled, are the infective form of the parasite. Mode of transmission: man acquires infection by ingestion of food and water contaminated with feces containing thick-walled oocyst, or by autoinfection. Thin-walled oocyst can infect the same host through contaminated fingers. Development in man: excitation oocyst gets dissolved in the small intestine, resulting four sporozoites. Invasion: sporozoites invade the brush border epithelium of the small intestine and lie inside a parasitophorous vacuole near the microvilli surface, within which all the stages of development take place. Schizogony: the sporozoites subsequently differentiate into trophozoites, which further develop into a schizont or meront. Schizont undergoes asexual multiplication, schizogamy, to produce merozoites. Gametogamy: the merozoites undergo gametogamy and transform into sexual forms, microgamete and macrogamete. Sporogamy: fertilization takes place between microgamete and macrogamete to produce the zygote. Now, in this figure, we can see the life cycle of Cryptosporidium. The sporozoites infect the man. These sporozoites attach to the brush border of intestinal epithelium. Next, trophozoites reside inside a parasitophorous vacuole. Schizont is formed, which releases merozoites. These merozoites can again invade adjacent enterocytes and later can differentiate into macro and microgamete. These fertilize to form the zygote. This is called schizogony. Okay, now the zygote forms thick-walled and thin-walled unsporulated oocyst. This is gametogony. The thick-walled are 80% while the thin-walled are 20%. The thick-walled sporulated oocyst, man acquires infection by ingestion of the food and water contaminated with thick-walled oocyst. Again, excitation in small intestine. While the thin-walled oocyst cause auto-infection of these sporozoites, again leading to an infection of Cryptosporidium. Now, the subsequently zygotes transform into both thick-walled oocyst and thin-walled oocyst. Then the oocysts undergo sporogony to produce four sporozoites. Sporulated oocysts are excreted in the feces, which are now infective to the same person, thin-walled, and other individuals, thick-walled. The life cycle of Cyclospora and Cystoisospora are similar to Cryptosporidium with the following differences. Autoinfection is not observed. The oocysts released in the human feces are unsporulated. The sporulation of oocysts takes place in the soil environment, whereas in Cryptosporidium, the sporulation of oocysts takes place in the human intestine. Epidemiology: although infection with intestinal coccidian parasites is seen worldwide, it is more prevalent in tropical and subtropical climates of developing countries from South America, Africa, and Southeast Asia, including India. The highest prevalence is reported from Haiti. Risk factors: it is more common in areas with poor sanitation and HIV infected individuals. Peak age: infants and children are commonly affected. Source of infection includes rainwater, lodges, and swimming pool recreational water, or contaminated food, example imported foods including raspberries, basil, and mesclun lettuce. Cryptosporum parvum is zoonotic, common in rural areas, and C. hominis is mainly a human parasite, more commonly seen in urban setting. Whereas for Cystoisospora, humans are the only host, there is no animal reservoir. A massive outbreak of cryptosporidiosis occurred in Milwaukee, USA in 1993, affecting more than 4 lakh people, transmitted through the contaminated public water supply. Now, coming on to pathogenesis, the pathogenesis of the intestinal coccidian parasites involves the following steps. Encystation, egg cystation first. Okay, the oocyst secretes proteases and aminopeptidases which facilitate egg cystation in small intestine, releasing sporozoites. Attachment: sporozoites attach to the brush border epithelium of the small intestine ileum. It is facilitated by the virulence factors such as CP47, 47 kilodalton cryptosporidium protein. Penetration: discharges from the apicomplex present in the anterior end of the sporozoites help in invasion. Vacuole: following penetration, the parasite forms a parasitophorous vacuole near the microvilli surface of the host cells. Cytokines: then the parasite activates the host immune system to release cytokines like tumor necrosis factor, TNF alpha, interleukin 8, prostaglandins, etc., which induce inflammation. These factors increase intestinal secretion of chloride and water and decrease the sodium absorption, leading to fluid loss and diarrhea. Cryptosporidiosis occur more frequently than cyclosporiasis and cystoisosporiasis. This may be attributed to various factors like low infective dose of Cryptosporidium 100 to 10 to 100 oocysts can initiate the infection. Small size of the oocyst 4 to 6 micrometer. Oocysts are resistant to available drugs and disinfectant including chlorination. Large animal and human reservoir and a zoonotic contact as well. Now coming to clinical features, immunocompetent host, the majority of infections remain asymptomatic. Some individuals develop symptoms after an average incubation period about 1 week. Watery non-bloody diarrhea is the most common presentation. Other features like abdominal pain, nausea, anorexia, fever and or weight loss may be present. Self-limiting subsides within 1 to 2 weeks. They can cause 2 to 6% cases of travelers diarrhea associated with traveling to developing countries. Immunocompromised host, example AIDS. Host immune status is not a primary factor for initiating the infection but plays an important role in determining the length and severity of the illness once the infection is established. HIV/AIDS is the most important immunocompromised condition. It produces a chronic persistent profuse diarrhea 1 to 25 liters per day, leading to significant fluid and electrolyte loss resembling cholera and diarrhea. Severe weight loss, wasting and abdominal pain may be seen. Extraintestinal manifestations are common such as biliary tract infection, sclerosing cholangitis, respiratory tract infection and pancreatitis. The disease is more severe in patients with AIDS when CD4 plus T cell counts become less than 100 per microliter. Other immunocompromised conditions include severe combined immunodeficiency syndrome, hematological malignancies and solid organ transplant recipient. Disease is more severe in Cryptosporidium than Cyclospora and Cystoisospora, which is attributed to autoinfection seen in the former, a key factor for maintaining the infection resulting in chronic persistent diarrhea. Coming on to lab diagnosis, direct microscopy, stool examination. Stool microscopy remains the most common method employed for diagnosis of intestinal coccidian parasitic infections. Sample collection: 3 stool samples should be collected. Rarely in HIV positive patients, sputum, bronchial wash, duodenal or jejunal aspirate can be collected. Direct wet mount. Direct wet mounting from the mucus plug of the stool sample is done to demonstrate highly refractile double wall oocyst. Concentration technique: if the oocyst load is less, then various techniques are used to concentrate the stool sample. Flotation technique like Sheather sugar flotation technique, widely used for coccidian parasites, or saturated salt flotation technique. Sedimentation technique like formalin ether sedimentation technique. Acid fast staining: the oocysts are acid fast to 0.5 to 1% sulfuric acid or acid alcohol and appear as red oocyst against the dark blue background. Quignon method: cold acid fast staining is the method of choice. The sensitivity of acid fast staining is low and it requires a minimum concentration of 50,000 to 5 lakh oocysts per ml of liquid stool and form stool respectively. In this figure, we can see the sporulated oocyst of Cryptosporidium in figure A, Cyclospora in B, and Cystoisospora in C. Okay. Now, coming to direct fluorescence antibody staining, it is available for cryptosporidiosis. The oocyst can be detected by using fluorescent labeled monoclonal antibody directed against cyst wall antigens. This test is more sensitive 10 times and specific than acid-fast staining. It is also useful to detect oocyst from water and other environmental samples. Currently, this method is considered as the gold standard test for cryptosporidiosis. Autofluorescence oocyst of Cyclospora fluoros when viewed under ultraviolet epifluorescence microscopy. It is a rapid and sensitive method, although not specific. Cystoisospora oocyst also show autofluorescence, but this property is not consistent like Cyclospora. Phase contrast microscopy is also useful. Oocyst. The oocyst of the intestinal coccidian parasites are highly refractile, double wall and acid fast. Difference between the all the three will be seen in the table. Cryptosporidium, the oocyst is round, measures 4 to 6 micrometer in size, contains 4 sporozoids. In Cyclospora, the oocyst is round, measures 8 to 10 micrometer in size, contains 2 sporozoids, each comprising 2 sporozoids. Okay, sporocyst, 2 sporocysts, each comprising 2 sporozoids. The oocysts are variably acid fast. That is 50% of the oocysts are acid fast and the rest are non-acid fast. Oocysts also exhibit autofluorescence. Now, cystoisospora, the oocyst is oval and larger, measuring 20 to 30 micrometer in length, contains 2 sporocysts, each comprising 4 sporozoids. Okay. Now, histopathology, various developmental stages of the coccidian parasites can be demonstrated from the intestinal biopsy specimens of the jejunum. We'll look at them. First, let us see the differences between Cryptosporidium, Cyclospora and Cystoisospora. Okay, the infective form in Cryptosporidium is sporulated oocyst, and in everyone it is sporulated oocyst only in both Cyclospora and Cystoisospora also. Diagnostic form is sporulated oocyst in Cryptosporidium, unsporulated oocyst in Cyclospora and Cystoisospora. Outbreak, frequent and large outbreaks of Cryptosporidium are seen, while common large of Cyclospora and occasional small outbreaks of Cystoisospora are seen. Zoonotic potential Cryptosporidium yes, Cyclospora uncertain, Cystoisospora no. Oocyst size Cryptosporidium 4 to 6 micron, Cyclospora 8 to 10 micron, and Cystoisospora 20 to 33 micron. Oocyst shape round in Cryptosporidium, round in Cyclospora, while oval in Cystoisospora. Sporulated oocysts contain 4 sporozoids in Cryptosporidium, 2 sporocysts each having 2 sporozoids in Cyclospora, while 2 sporocysts each having 4 sporozoids in Cystoisospora. Acid fastness, uniformly acid fast are Cryptosporidium, variable acid fast are Cyclospora, and uniformly acid fast are Cystoisospora. Autofluorescence, no, but can be stained with fluorescent dye. About Cryptosporidium, autofluorescence present in Cyclospora, and autofluorescence may be present or not in Cystoisospora. Sporulation of the oocyst occurs inside the host cells, enterocytes in Cryptosporidium, occurs in soil environment in Cyclospora, while occurs in soil environment in Cystoisospora. Treatment is by nitazoxanide in Cryptosporidium, while cotrimoxazole is used as treatment in Cyclospora and Cystoisospora. In these figures, we can see the Cryptosporidium species. A figure shows acid fast stain showing red color oocyst against blue-black background. Okay, now in figure B, we can see direct fluorescent antibody staining showing brilliant green fluorescent oocyst. And figure C shows hematoxylin and eosin stain of intestinal biopsy showing numerous oocysts at the luminal surface of the intestinal crypts marked by arrows. In figure 45.17 A to D, we see Cyclospora species. A shows saline mount preparation showing unsporulated oocyst. B shows epifluorescence microscopy showing autofluorescent oocyst. C shows acid fast oocyst, while D shows non-acid fast oocyst variable acid fastness. In figure 45.18, we see Cystoisospora belli. A shows saline mount preparation, shows left unsporulated oocyst and right sporulated oocyst. B shows modified acid fast staining showing unsporulated oocyst. C shows phase contrast microscopy showing unsporulated oocyst, while D shows fluorescent stain smear showing unsporulated oocyst. When stained by H&E, stained cryptosporidium appears as 1 to 3 micrometer basophilic round bodies within the cell membrane of enterocyte called as blue beads. Now, antigen detection from stool. It is available for cryptosporidiosis. ELISA has been developed to detect C. parvum specific coproantigen, oocyst antigen from stool, shows a sensitivity ranging from 66% to 100% with excellent specificity. ICT is also available, example triage parasitic panel for simultaneous detection of antigens of cryptosporidium detecting protein disulfide isomerase antigen. Giardia and Entamoeba histolytica, it shows sensitivity 83 to 96% and specificity 99 to 100%. Antibody detection. Methods such as ELISA are available detecting antibodies in the patient's serum against oocyst antigen of cryptosporidium or cyclospora. This is useful for pseudoepidemiological purpose, not for routine diagnosis. Now, molecular diagnosis. Molecular methods such as PCR or real-time PCR can be performed to detect specific genes from both clinical and environmental samples, targeting genes such as 18S rRNA or small subunit rRNA. Molecular methods are more sensitive, take less time, and can differentiate between Cryptosporidium, Cyclospora, and Cystoisospora. It can also differentiate various genotypes of Cryptosporidium, which play an important role in outbreak situations. Biofilm array, it is fully automated commercially PCR system from Biomerics. The gastrointestinal panel is used to detect common bacterial, viral, and parasitic Cryptosporidium, Cyclospora, Entamoeba Giardia, diarrheal pathogens. Other methods. Low CD4 T lymphocyte count, especially in HIV positive patient. Fecal leukocyte marker lactoferrin is increased in 75% of the cases, indicating increased pus cell in feces. Now, the treatment of intestinal coccidia infection, mild are cases are self-limiting, requires fluid replacement like ORS, lactose-free glutamine, supplemented diet is preferred for cryptosporidiosis. In severe cases for cryptosporidiosis, nitazoxanide is given to adults for 3 days. It is not effective in HIV-infected patients. Paromomycin can be given as an alternate. In cyclosporiasis and cystoisosporiasis, treated with cotrimoxazole for 7 to 10 days, HIV-infected patients may experience relapses and may require long-term suppressive maintenance therapy. Patients who cannot tolerate cotrimoxazole may be treated with ciprofloxacin or nitazoxanide. Now, the prevention requires minimizing exposure to infectious oocysts in human or animal feces, proper hand washing, use of submicron water filters, use of appropriate disinfectants, sterilant to kill the oocysts, such as hydrogen peroxide, steam sterilization, improved personal hygiene are some of the efforts to prevent transmission. Now, coming on to other intestinal protozoan infection, which is the last part of the chapter. Other protozoan parasites which can cause intestinal disease in man include Bacillium coli, Saccharomyces species, and Blastocystis hominis. Involvement of intestinal muscles occurs in chronic Chagas disease caused by Trypanosoma cruzi. Bacillantidiasis. Bacillantidiasis is an intestinal infection caused by protozoan parasite Bacillantidium coli. It is largest protozoan and only ciliated parasite of humans. It produces intestinal disease similar to amoebic dysentery. Habitat. It resides in large intestine similar to Entamoeba histolytica. Host pig, main reservoir, and other animals are the primary host. Man is an accidental host. Morphology. It exists in two forms: trophozoite found in the dysenteric stool, cyst found in carriers and chronic cases. Both forms are binucleated, having a large macronucleus and small micronucleus. Life cycle: man gets the infection by ingestion of the food and water contaminated with cyst infective form. Cysts transform into trophozoites which then multiply in the large intestine by both asexual mode and sexual mode conjugation. Both trophozoites and cysts are excreted in the feces. Trophozoites disintegrate but the cysts are resistant and infective to man and pig. Clinical features: majority of infected individuals become asymptomatic carriers. A small number of people develop acute dysenteric disease. Characterized by profuse diarrhea and dysentery with mucus and blood weeks to months later. Other features include fever, nausea, vomiting, and abdominal pain. The disease is similar to amoebic dysentery except that it is less severe. Invasion is limited to muscularis mucosa. Intestinal ulcers are superficial and extraintestinal involvement occurs very rarely. Epidemiology. B. coli is worldwide in distribution, particularly in tropical and subtropical countries where pig to human contact is more. However, it is rare in India. Lab diagnosis: repeated stool examination should be done as the parasite is excreted intermittently Trophozoites are appreciated in the saline mound, whereas internal structure of the cyst are seen more clearly in the iodine mound. Trophozoites. They are detected in acute disease dysenteric stool, oval shaped 50 to 100 micrometer in length and 40 to 70 micrometer in breadth, exhibit rotatory motility due to the presence of cilia covering the whole body. Binucleated, having a kidney shaped large macronucleus and small micronucleus. Cysts are seen in chronic cases or in carriers. The cyst is a round shaped, measures 50 to 70 micrometer in size, surrounded by cyst wall and has two nuclei. Histopathology. Histopathological staining of the biopsy tissue or scraping of the ulcers taken by sigmoidoscopy reveals a cluster of trophozoites, cyst, and lymphocytic infiltration in the submucosa. Treatment: tetracycline is the drug of choice given for 10 days. Alternatively, metronidazole can be given. Prevention: Balantidiasis can be prevented by treatment of the carrier, shedding the cyst, hygienic rearing of the pigs, and prevention of the pig to human contact. Prevention of contamination of the food or water with pig and human feces. Okay, now coming on to blastocystosis. Blastocystosis is the infection caused by protozoan parasite Blastocystis hominis. It resides in the intestine of many animals, including humans. It was considered as the most common commensal protozoa of intestine. However, recently its pathogenic role has been described. This is the morphology of Balantidium coli with the cilia, food vacuole, macro and micronuclei, and contractile vacuole. In figure B, we can see the cyst of the Balantidium coli. In these figures, we can see the Balantidium coli A saline wet mound, a preparation showing the trophozoite with cilia, and in B, we can see iron hematoxylin stain showing cyst with prominent macronucleus. Now coming back to blastocystosis, taxonomy is now classified under the kingdom Chromista, but for the sake of familiarity, it is considered under protozoa. Morphology: Blastocystis species show great morphological variations, occur in six forms: vacuolar, avacuolar, multivacuolar, amoeboid, granular, and cyst forms. Life cycle: cysts are the infective form transmitted by fecal-oral route. Cysts develop into vacuolar forms in the intestine, then multiply and transform into other forms, and vice versa. The vacuolar forms transform back to cyst. All forms can be shed in the feces, however, only cyst can survive in the environment. Pathogenesis: most infected individuals are asymptomatic carriers, few present with symptoms of irritable bowel syndrome such as abdominal pain, bloating, flatulence, and diarrhea. However, its pathogenicity is doubtful. Ruling out other enteric parasites, it is necessary before attributing symptoms to blastocystis. Lab diagnosis: stool microscopy by permanent stain smear trichome stain is the procedure of choice which demonstrates various forms of blastocystis. Vacuolar forms are the most forms seen in stool microscopy. They measure 5 to 15 micrometer in size with 1 to 4 nuclei and a large vacuole in the cytoplasm. Other diagnostic methods include antibody detection by ELISA and molecular methods such as PCR targeting small subunit rDNA. Treatment: metronidazole is found to be effective used alone or in combination with paromomycin or nitazoxanide. Now coming on to the intestinal sacrocystosis. It is zoonotic parasite infection caused by Sacrocystis hominis, infects cattle. Sacrocystis sui hominis infects pigs. Human infection is extremely rare. Host: dogs and cats, and accidentally man are definitive host, whereas cattle, pigs serve as intermediate host. Okay, in these figures we can see the blastocystis species showing vacuolar forms. A shows saline red mound, B shows iodine mound, and C shows a trichome stain. About intestinal sacrocystosis, it's worthy to note that occasionally man acts an intermediate host which leads to development of muscular sacrocystosis. Now, the life cycle: infection is transmitted to man by ingestion of beef or pork infected with sacrocyst, which transform to oocysts in the intestine that are released in the feces. Clinical features: it is usually asymptomatic, but patient may develop nausea, vomiting, abdominal pain, and diarrhea. Diagnosis is diagnosed by stool examination demonstrating the oocyst. Treatment: no specific treatment is available. Infection is generally self-limited. Now coming on to Chagas disease, then chronic Chagas disease, the causative agent is Trypanosoma cruzi, multiplies in the muscles of GIT, leading to megaesophagus manifested as dysphagia, chest pain and regurgitation, and megacolon manifested as abdominal pain and chronic constipation. Okay, So this completes our protozoan infection. Now coming on to fungi causing the intestinal infection. Microsporidiosis. Microsporidia are the lower eukaryotic spore forming obligate intracellular parasites cause opportunistic infection in HIV infected patients. Taxonomic status. Microsporidia were once classified under parasite, now considered to be evolved from fungi, being most closely related to zygomycetes. Classification based on the habitat, Microsporidia include over 170 genera infecting a broad range of vertebrates and invertebrates. However, only few are found to infect man, producing various manifestations ranging from intestinal, musculoskeletal, and ocular infections. Spore Microsporidia exist in nature as spore. Spore is highly resistant extracellular forms. It survives in the environment. It is also the infective stage. It enters to the host cell via a polar tube within a spore. Life cycle. Humans acquire infection by ingestion or rarely inhalation or ocular contact of spores of Microsporidia. Spores come in contact with the host cell, example enterocyte, and inject its cytoplasm called sporoplasm with the help of a polar tube. They multiply inside host cell first by asexual mode producing merons and then by sexual mode sporogony, producing sporons that subsequently develop into spores. Epidemiology. Microsporidia infections have been increasingly reported in AIDS patients from North America, Europe, West Europe, and Australia. In India, few clusters of cases have been reported so far. Pathogenesis and clinical features. Microsporidia mainly cause opportunistic infections in HIV infected patients when their CD4 T cell count falls below 100 microliter or in any other patients with immunosuppression like recipients of organ transplant. Depending upon the species causing infection, clinical presentation of the microsporidiosis may be of various types. Enteric infections. Agents include enterocytozoan and encephalitozoan. Ocular infection agents include nosema, vitaforma, microsporidium, and others. Myositis infection of the muscle agents include Plistophora, Trachyplistophora, Brachiola, and Anacalia. And disseminated infection by tubulinosema. Okay. Now coming on to the lab diagnosis, light microscopy for the spore detection. Various samples can be collected like stool, small intestinal contents collected by enterotest, corneal smear, or small intestinal biopsies, sputum, urine, etc. Modified trichome stain (MTS) is the recommended stain for Microsporidia. Microsporidia appear as red oval reflectile spores against a blue background. Modified acid fast stain Microsporidia spores are acid fast to 1% acid alcohol, appear red 1 to 1.5 micrometer in size. Gram stain Microsporidia spores stain gram positive. Other stain Ginsa stain, periodic acid shift stain, pass, gram chromatope stain, and fluorochrome stain like chalcofluor white stain can be used. Now coming to electron microscopy, it is considered as the gold standard method for the diagnosis of microsporidiosis. It helps in identifying microsporidia to the genus and species level. It is highly specific but lacks sensitivity. It is also time consuming, labor intensive, and expensive. Other methods include cell culture. Microsporidia have been successfully cultured in number of cell lines including monkey kidney cells viro, human fetal lung fibroblast cell line. Its use in routine clinical diagnosis is limited as it is time consuming and laborious. Antibody assays, various methods like indirect immunofluorescence, ELISA, and Western blot are available to detect antibodies. They are not very useful as they lack specificity. Antigen assays, direct antibody fluorescence test DAF is available for detecting the antigens or microsporidia spores. Molecular methods, PCR based methods have been developed targeting different genes like small subunit gene of rRNA for diagnosis and speciation of microsporidia. In situ hybridization has been established for the detection of E. bionc in humans by using probes directed against small subunit rRNA of E. bionc present directly in the biopsy specimens. Now coming to treatment, albendazole is effective for the treatment of enteric, muscular and ocular microsporidiosis. It is given 400 mg twice daily for 2 to 4 weeks. Relapse may be seen in some cases. Other alternative drugs which are tried include octreotide, nitazoxanide, flumaglidine and itraconazole. Nutritional therapy to reduce malabsorption in case of enteric microsporidiosis can be given. Topical agents can be applied for the corneal lesions like topical itraconazole, metronidazole, and topical propamidine. Control of AIDS by antiretroviral therapy is important to reconstitute the immune system and to prevent remissions. Now, in these figures, we can see Microsporidia spores. A shows modified trichome stain, B shows acid fast stain showing red stain mature spores and blue stain non-acid fast spore, immature or degenerating spores. C shows duodenal biopsy with Giemsa stain showing numerous spores inside the enterocytes, marked by arrow, and D shows electron microscopic picture. Lastly, let us discuss the classification and clinical manifestation of Microsporidia. Genus Enterocytozoon, species E. bionsi, habitat and infection. Most common species infecting man, small intestine enteric infection, diarrhea, A. calculus cholecystitis, rarely can cause nasal polyp, infection of the bile duct, liver, and respiratory system. It has a zoonotic potential. More than 90 genotypes are described, only 17 infect humans, most common being group 1. Encephalocytozoon E. intestinalis, second most common species infecting man, small intestine enteric infection. E. cuniculi, extraintestinal infection such as disseminated systemic infection. In eye, it can cause keratoconjunctivitis. In sinuses, it can cause chronic sinusitis. In CNS, it can cause brain abscess, heart, myocarditis, and endocarditis, respiratory and genitourinary tract infections. E. helem, disseminated infection involving eyes, keratoconjunctivitis, urinary tract, and respiratory tract. Transmission is from birds. Now, Plistophora species is P. ronanaphi. Skeletal muscle myositis infection can be caused. Next is Trachyblistophora species is T. hominis. It can cause myositis, sinusitis, and conjunctivitis. T. anthropophthora. It can cause brain infection, heart, and kidney disease. Next is Brachiola species B. vesicularum, can cause skeletal muscle and corneal stoma, corneal ulcer. Next category is Anacalia. A species involved is A. conori. It can cause eye, corneal stoma, smooth and cardiac muscle infection. And A. allegri. It can cause eye, muscle and possible disseminated infection, and mosquito-borne transmission is documented. Nosema species N. ocularum, eye or corneal stoma is involved. Vitaforma V. cornea, eye, corneal stoma, and rarely urinary tract UTI. Waterborne transmission has been documented. Tuberculosema T. acridophagus, systemic disseminated infection is there. Grasshoppers are the non-human host. And last category, Microsporidium M. cyanosis is there, which can cause corneal stoma, corneal ulcer of the eye. And M. africanum, it can also cause the corneal stoma of the eye. Most of the species are zoonotic, having various animal reservoirs. Okay, so this completes our intestinal protozoan infections. Let us come to the questions. A 17-year-old boy present with bloody diarrhea with mucus and pus cells, colicky abdominal pain with fever and prostration. Wet mount examination of the stool sample was formed which showed trophozoites 5 to 20 micrometer, actively motile with finger-like pseudopodia. This is clearly a case of Entamoeba histolytica, amoebic dysentery. Can cause, will write the etiological agent, pathogenesis, and the diagnostic modalities. A 46-year-old female patient infected with HIV presented to casualty with severe profuse diarrhea with a frequency of 15 times a day for the past 10 days. She also complained of the weight loss and abdominal pain. The stool specimen was subjected for modified acid-fast staining, which revealed round sporulated oocysts 4 to 6 micrometer in size, containing 4 sporozoites each. This is a case of Cryptosporidium. Etiological agent, life cycle, diagnostic modalities, and clinical conditions we can write. Now, short note on a 3-year-old boy presented with recurrent episodes of foul smelling diarrhea, foul flatus, sulfurous belching, and profound weight loss. Wet mount examination of the stool sample revealed pear-shaped trophozoites with falling leaf-like motility. What is the etiological diagnosis and what are the diagnostic modalities? So, falling leaf-like motility in Giardia. So, this is a case of Giardia lamblia infection. Okay, so we can write the diagnostic modalities and all. Next is infection caused by Microsporidia. We can write the table that we are studying right now. Now, the infective form and invasive form of Entamoeba histolytica are Trophozoite conucleated cyst, no. Quadrinucleated cyst and trophozoite, it is correct. A sporulated oocyst of Cystoisospora belli contains two sporocysts with four sporozoites each. Okay. Sporulated oocyst of Cyclospora catenaris contains two sporocysts and four sporozoites. Okay. Which statement is false about Cryptosporidium species? Development stage of parasite occur inside a parasitophorus vacuole. It is true. High infective dose? No, it is high. It has a low infective dose of 10 to 100 uh, infective agents only. Large number of animal reservoirs are there. It can cause diarrhea in AIDS patient. It is true. Intermittent host for Saccharocystis sui hominis is, of course, sui stands for pig, so it is a pig. Okay, Microsporidia spores are better stained by which of the following stains? It is the modified trichome stain MTS. Okay, next, which of the following bears two nuclei named as macronucleus and micronucleus? The macro and micronucleus were there in Balantidium coli. Okay, so this completes our chapter. Next, we'll be starting with intestinal helminthic infections. So, like to subscribe. Thanks for watching.